Good afternoon, everyone. My name is Janay, Duncan, and today I'll be presenting my literature review on the article Diagnosis Dilemmas in Vital Pulp Therapy. Treatment for the toothache is changing, especially in young, immature teeth. The article was written by Joe H. Camp. The name of the journal in which the article was published was a Journal of Endodontics. The date of publication, May-June 2008. Major topic, vital pulp therapy in primary teeth or immature teeth, and the type of article was a review or a critically appraised topic, evidence synthesis. Now we will move to the main purpose of the article. The purpose of this article was to review the dental literature and new research in vital pulp therapy, to discuss the current techniques of indirect pulp therapy, pulp and pulpotomy for primary teeth as well as permanent teeth with open apexes. It highlights the diagnosis and treatment of affected immature permanent teeth as well as primary teeth. Below we can see the image depicting a pulpotomy on the left, and on the right it depicts the process of an indirect pulp cap in which 2 millimeters of decay is left adjacent to the vital pulp. Next, I'll be discussing the key points in the article. The treatment options proposed are usually based on the diagnosis of tooth root development stage. The tooth root development begins after enamel and dentin formation has reached the cemento-enamel junction, or CEJ. Hertwig's epithelial root sheath is formed by the epithelial dental organ with one tube for each of the future roots. As root formation proceeds apically, each root is wide open, diverging apically and limited by the epithelial diaphragm. Once root length is established, however, the sheath will disappear, whereas dentin deposition will continue until root formation is completed. Therefore, it is important to have a thorough knowledge of the normal root formation and the differences between developing and fully formed root. Each root internal surface is also lined by odontoblasts, and there is continued dentin deposition that causes narrowing of the canals, and the apex will eventually close with dentin and cementum, creating an apical convergence. In permanent teeth, root formation is not completed until 1 to 4 years after eruption into the oral cavity. With the exception of single-rooted teeth, radiographs cannot determine apical closure. Therefore, the clinician must rely on time to determine root closure in all other teeth. That's why it's important to know the eruption sequence in permanent as well as primary teeth. In the formative period of teeth, treatment should be focused on maintaining the vitality of the pulp as well as influencing continued root development and closure. It's said that because there's a difference in the width between the facial lingual as well as the mesodistal width, and facial lingual width of most roots and canals is greater than the mesodistal width, and apical closure will not be visible on the radiograph. Now we move to the factors that complicate the establishment of working length if root canal therapy is necessary. The first one is that the root canals of primary teeth differ greatly from those of permanent teeth, and treatment is complicated by apical resorption to allow for eruption of the succeeding teeth. The second is that continued physiologic apical resorption of the roots makes the teeth progressively shorter. Third, resorption is initiated on the primary root's lingual surface. This results in the apical foramen moving more coronally. So it is important to note that most roots have only one canal, but because of continued deposition of dentin, it might divide the root canal into 2 or more, and these variations are not really visualized on the radiograph in the facial or lingual plane. How to diagnose the pulpal status in primary teeth? So as we know, every diagnosis should start with a thorough history and before the examination begins. So we want to identify any pain and the characteristics of pain, such as we want to find out the history of the pain. We want to see if it's spontaneous, if it's reversible or irreversible, what kind of stimulus causes this pain, the onset of the pain, the duration, relieving or aggravating factors, as well as the severity of the pain, which we can use a scale from 1 to 10. Now we move to the clinical examination, where it might produce evidence of pulpal pathology. We can percuss. We can see if there's any mobility, but there might be mobility because it's a normal physiologic resorption. Because of normal physiologic resorption, sorry. Electric pulp tests are not valid in primary teeth. Doppler fluorometry might be of greater help to determine vitality. And thermal tests are not usually conducted in primary teeth because of their unreliability. We also want some radiographs of good quality as an aid in diagnosis. So you can have a bite wing radiograph, are often best to observe pathologic changes in posterior primary teeth. We also want a periapical radiograph to see if there's any periapical radiolucency that may appear. For primary anterior teeth, the periapical radiolucency is usually at the apex. In primary molars, they appear in the bifurcation or the trifurcation areas. And interpretation of radiographs of primary teeth is always complicated by the presence of the succedaneous tooth and surrounding follicle that may cause it to be cause a misdiagnosis. All carious exposures are accompanied by pulpal inflammation. The larger the exposure, the more likely it is to be widespread or necrotic. So if the tooth appears deep purple colored, it may indicate the presence of hemorrhage, and these teeth are candidates for pulpectomy or extraction. Studies have shown that 1 in 3 children receive traumatic injuries to the primary dentition, and most of these injuries are a displacement. We'll discuss a study conducted by Borum and Andreessen of 545 traumatized primary maxillary incisors, and they found that 53% of subjects developed pulpal necrosis and 25% developed pulp canal obliteration. So in the image on the right, we see clinical signs of pulp necrosis where the tooth appears discolored. Factors found to influence development of pulp necrosis included age, degree of displacement, and concurrent crown fracture. Calcific obliteration of the canal was influenced by tooth displacement and amount of root resorption, and crown fracture decreased canal obliteration. So in dentistry, there's a lot of conflicting data on whether dentists should treat primary teeth injuries or if they should just extract it. So studies have shown no relationship between treating injured primary teeth compared with extraction of primary teeth, and it says that it doesn't disturb the growth or development of the permanent tooth. However, other studies show that it has a tendency toward more extensive disturbances in mineralization when injured primary teeth were retained. So most studies agree that avul's primary incisors should not be replanted because of the possibility of danger of the permanent tooth bud. Also, traumatized primary teeth present for treatment where they develop some kind of transient or permanent discoloration, and these colors vary from yellow to dark gray and usually become evident around 1 to 3 weeks after trauma. So as seen in this image, it's saying that pulp canal obliteration or pulp canal calcification usually appears in a yellowish discoloration. So as we see that from the first day of injury, around 3 weeks after that, you're going to see a reddish brown discoloration occurring, and if it's left, then it can lead to pulp necrosis, where you'd get a dark gray or a purple presentation. So the image on the left, it depicts the dark gray discoloration of the crown of the maxillary primary central incisor, which is a clinical sign of pulp necrosis. While on the right, we're seeing the same discoloration, but it's on a permanent maxillary central incisor. Diagnosis of pulpal status in permanent immature teeth. Numerous scientific studies have been reported on the treatment of permanent teeth with immature apices, and the literature is almost devoid in areas of diagnosis. In immature teeth, the frequency of fractures was dependent on the stage of root development, ranging from 77% in the least to 28% in the most developed roots. In a 4-year study, Speck noted significant increase in cervical root fractures in treated immature teeth compared to those with completed roots. So if you have a loss of vitality before completion of root length, it can lead to a poorer crown root ratio. It can lead to periodontal breakdown, and it can also lead to mobility. So diagnosis of pulpal status in immature permanent teeth is not very different to that of primary teeth. The thermal tests with heat in permanent teeth with developing apices are often of limited values. The radiographic examination is important to diagnose pulpal pathology in teeth with developing apices. You can do a periapical radiograph, which allows you to view the root development and if there's any pathology present. You can do a bite wing radiograph, and it allows the detection of caries, proximity of the lesion to the pulp, and previous dental treatment. So there is a universal agreement that exists that immature teeth have the greatest potential to heal after trauma. Therefore, these teeth have the greatest chance of misdiagnosis or mistreatment, and the following factors are key in making the diagnostic determination. So you have factors such as bone loss, mobility, tenderness to percussion, arrested root development, symptoms of irreversible pulpitis. And if you are doubtful, you don't want to start treatment, you want to keep the patient under close observation and follow up. In terms of treatment, the use of calcium hydroxide, pulp capping, and pulpotomy procedures in permanent teeth is being replaced with composite resins and mineral trioxide aggregates, or MTA. When compared with calcium hydroxide, MTA produced significantly more dentinal bridging in a shorter time with less inflammation and less pulpal necrosis. MTA has been shown to be cementoconductive, and it has attachment of cementoblasts which deposit cementum to form an apical barrier or to aid in root development. Apical barrier techniques with MTA now allow timely completion of apexification and have eliminated the use of calcium hydroxide except for the use as a temporary canal disinfectant. Okay, so in A, we see that is a preoperative radiograph of the maxillary permanent left central incisor, where the pulp is necrotic and the apex is open. So in B, they placed a 4mm plug of MTA at the apex. As you can see, it's radiopaque. And in C, the remainder of the canal was restored with composite resin. So we move on to D, where you have a 2.5-year follow-up, and you see that the apex started to converge or converging of the MTA with cementum and closure of the apex and healing of the periapical lesion formed from the pulpal necrosis. Assessment of article. This article can fall under the category of evidence synthesis or critically appraised topics, which is a type of review. Because it combines information from multiple studies that have investigated the same thing to come to an overall understanding and conclusion about what they found, it allows one to establish how effective a certain treatment method is. It also allows researchers to bring together all relevant information on a research question, and it is useful in identifying any knowledge gaps and establishing the best practice guidance. The article spoke to different studies and used various scientifically knowledgeable articles in order to obtain information about the topic at hand and to provide some evidence. This article was published by the Journal of Endodontics, which is considered a credible and reliable source of information in dentistry, where a credible source is one that is unbiased and it is backed with evidence. This article mentioned several studies and experiments that were performed to support the information or conclusions stated in the article, and also included radiographs and clinical images to support the evidence and findings. This is my reference, and I'd like to thank you all for watching this video.